Side one. Side over. The era of the new millennium, proceeds, benefits, conflicts, purely from love. Right, so these are a relatively infrequent fracture in the complete scheme of things, but relatively frequent in terms of tarsal fractures. Working males are disproportionately represented in the calcaneal fracture group, and there's the associated injuries that you have to look for. Okay. The much talked about one is the rate of lumbar spinal compression fractures, and it's the order of 10% in people that fall from heights of greater than a metre. But there are other injuries that have been described, and for many years people have known that these have been bad. Con even back into 1935 described that. Sorry, that was really dumb. Right, so unlike the talus, this is a very articular bone. Okay. There are essentially 3 articular facets, although the anterior and middle facet often form a single larger one, and an extra articular body. On the lateral side, the surface anatomy is just a perineal tubercle that runs between, or splits the brevis anteriorly and longus posteriorly. And on the medial side, underneath the sustentaculum, is the FHL. Now, as you guys all know, the FHL is a relatively posterior structure, and the vessels and all the bad things are anterior to it. So, in a sense, the back half of the calcaneum is a relatively safe zone. It's hard to wreck anything bad. Safe for calcaneal osteotomies, relatively safe for screw fixation. Okay? And so in fixing calcaneal fractures, one of the semi-fortunate things is that neurovascular injuries are relatively uncommon because for the most part, the vessels are out of the way, like all anterior to the FHL, which runs under the sustentaculum at the top. We need to know what the calcaneum looks like. Bowler described Bowler's angle from the top of the tuberosity, the top of the posterior facet, and a line subtended from the top of the anterior process between 20 and 40 degrees, and in the articular joint depression type fractures, you can get to 0. 0 is pretty bad, and if you really squash them down, you can get into negative angles where instead of sitting that way, it can go that way. The angle of Gassein is another, in a sense, I think it's a bit easy. You can just sort of eyeball it and say, well, it's an acute angle or it's not. If it's an acute angle, that's bad, okay? So it's got to be more than 90 degrees. And that's just the junction between the anterior and posterior portions. So, the mechanisms of injuries. Really, the extra-articular ones tend to be the lower energy ones. People avulse bits of bone with the tendon Achilles. There's twisting injuries with the anterior process, and they'd be the commonest ones. They tend to be twisting forces or occasionally stress fractures. The intra-articular ones are much more interesting. So the most troublesome ones, they tend to form the majority because so much of the calcaneum is articular and associated with falls of greater than a metre. At the Alfred, we see a fair few from molecular accidents as well. The great things about bones in the body is they fracture in really consistent patterns no matter where you are. And the calcaneum is no different. So you fall, and what happens is that the medial ligament stabilises the sustentaculum. Okay. So you think of it as that stays put relative to the medial malleolus. You come down, and the first thing that happens is there's almost a sagittal plane split that separates it into a supromedial fragment and the rest, the body part. Sometimes that sagittal plane split doesn't stay sort of relatively extra-articular. Most commonly, actually, it goes through the posterior facet of the talus and splits it up into a supramedial and supralateral portion. And that portion, with a bit more force, drives down and blows out the lateral wall as well. That's how you usually get your, that's when it becomes a bit more squashed. So that supralateral fragment drives down, rotates a little bit and pushes out the lateral wall. So Carr got a whole lot of BKA specimens and put weights on them and dropped them from heights and worked out how these actually broke. And as I said, it's remarkably consistent. There's that longitudinal, essentially sagittal plane split, which is number 2 over here. And then there tends to be a transverse split in that angle of descent. In other words, between the posterior and the anterior facet. Okay. What's a bit more variable, so that's number 1. So you get that and you get number 1 through the angle of descent. What is more variable is where number 4 exits out. Okay? If it exits out transversely, you tend to get the joint depression type of fracture. So that's number 1, that's number 2, and where this exits out decides whether you get the parrot beak, the beak type fractures, or whether it becomes that rotated joint depression type. So that, if it exits out laterally, as in the upper diagram, is what you get with the joint depression. And if that doesn't exit out the side here, but exits out there, is when it tends to lift up with a bit of the tendo Achilles and gives you that posterior stick up fragment. Different fracture patterns cause different effects. Okay. Fundamentally, comminution makes bad joints, and that's when people tend to get more arthrosis from. The more squashed it is, okay, the wider it is. And I don't know, do you guys, when you get a really flat calcaneum, are you aware that that actually affects your ankle motion? It's a well understood, poorly understood concept. Don't all jump up at once. Oh, we'll go poorly, okay. We'll assume it's poorly, okay. So what happens is that if you normally have a talus that sits down on that plane, okay, and a calcaneum that sits up on that plane, and that angle, kite or whatever you want to call it, is between 20 and 40 degrees, okay? So what happens is when you squash the calcaneum, it becomes more parallel to the talus, which means to get your heel back on the ground, you have to articulate with the front half of the talus, right? That's clear? So that means that you don't have as much leftover articular surface at the front to roll into dorsiflexion. So when you see patients that turn up with malunited calcaneal fractures that are very short, they often have limited dorsiflexion of the ankle, and that's one of the rationales for this distraction arthrodesis that we sometimes think about, just to get that relative angle back, is to give them back that dorsiflexion. So when you're very short, it will affect ankle motion. It gets wide as well, particularly when you blow out the fragment, and that impacts on shoe wear. And the other thing that happens with these fractures is they tilt into varus, okay, and displace laterally. So when it does that, they displace laterally, they're shorter, and that's when you get the impingement. So as you can see, the different types of fracture pattern and the way that they go have the obvious sequelae that occur. So someone comes in with a calcaneal fracture, and you get an X-ray. And you look at it and you go, oh, it doesn't look too bad, it's not perfect film, can't really see the subtalar joint. Just make sure when you do it, is you have a look at this. But what has actually happened is, this is that joint depression one, not the one that goes out through the back, the joint depression one. And as you can see, that this should mirror that. That lateral half, so if the medial half of the posterior facet stays put, you'll retain your bowler's angle. But the lateral half can be rotated through 90 degrees, and because you're looking at the medial side, a bowler's angle can be misleading. So the way I look at it is, If a bowler's angle is abnormal, it's abnormal. Okay, if a bowler's angle is not abnormal, it can still be abnormal. Okay, so it's good if it's positive, not so good if it's negative. And that's what that we refer to as this, the double density resident tract. So AP X-rays of the foot will usually tell you if it extends into the calcaneal cuboid joint. Broden's view, which I think is pretty difficult to do, useful intraoperatively to check on your reduction, but really not, certainly not really applicable in the acutely fractured, calcaneum. But it basically relies upon, you don't necessarily have to know this bit of internal rotation. Depending on the angle of the foot, you'll see different portions of the subtalar joint working your way backwards. But really, CT is the gold standard. And here's an example of, this displaced fracture with that supralateral fragment that's gone down here and punched out that lateral wall. Okay. So, the extra-articular ones form roughly a third. There are descriptions that are anatomical and relatively useless because they don't impact on prognosis or treatment, but are useful in a research setting, and that's about all. The intra-articular ones are a little bit better. Now, the X-ray ones are about as useful as that. Because basically, again, they're anatomical and don't really guide treatment or prognosis. Okay, Essex Lopresti divides them into those joint depression and the tongue types, in other words, that beak at the back. And it helps guide treatment a little bit because it tells you where to look for the fragments, but doesn't give you any prognostic sign. There's a number of others that are also equally unhelpful. So really, the only one you need to know is this thing, this Sanders thing, and the diagram looks terrible, and there's 10 different subdivisions or a bunch of subtypes. It's only one thing you've got to remember. So you look at the widest bit of the calcaneum on your CT scan. It's usually the bit through the sustenance